Hello, everyone. My name is Alexis Davis. I'm the social media manager here at RSDSA. And tonight I'm joined by Jim Broach, Executive Vice President and Director of RSDSA, and Dr. Richard Rauck. Dr. Rauck graduated from Wake Forest University's Bowman Gray School of Medicine in 1982. He received his bachelor's degree from Davidson College in Davidson, North Carolina, and graduated magna cum laude. He completed his residency in anesthesiology in 1985 at the University of Cincinnati College of Medicine in Cincinnati, Ohio. In 1986, he completed a fellowship in pain medicine at the University of Cincinnati's College of Medicine. He's a board-certified physician in pain medicine and anesthesiology. He has been actively engaged in clinical research in pain medicine, speaks frequently at many national and international professional meetings, and has an active clinical practice in pain management. He's currently practicing pain management at Carolina's Pain Institute and is the medical director for the Center for Clinical Research. Now, please remember, while the information shared here tonight is helpful, please consult your physician for personalized medical advice. And before we kick everything off, we do have a few announcements, a few things that we want to remind you all of and to tell you. So of course, it's CRPS Awareness Month. Please continue to sport your orange on social media, tag us, tag Color the World Orange. We want everyone to see you in your beautiful orange, and we definitely want more people to know more about CRPS. So please continue to wear your orange and to tag us. The second edition of our mini newsletter in rare form was sent out earlier this week. We hope that you all were able to see it on social media or via our email newsletter. So if you want to see a link to that, of course, I'll add it to the chat, but I definitely hope you all are enjoying it. You're loving all the news we're putting in it. Just, give us feedback on that, because we definitely want to make sure that we are, giving you exactly what you need. The next announcement, we have a really exciting networking event that we're actually going to host next Thursday, November 19th at 7 p.m. Eastern. So if you attended our virtual conference, there was a special feature of the platform that allowed CRPS warriors to network with one another one-on-one. And so many people loved it. We heard so much positive feedback that we said, hey, we should do this again. So we're going to do it again with a platform called Icebreakers. And like I said, we're going to host it next Thursday, November 19th at 7 p.m. Eastern. I'm going to share the link tomorrow, and the first 40 people who sign up get to participate. And I'm sure some of you are like, only 40? Why only 40? We're testing it out, and if 40 people show up and everyone loves it, we're going to, try to expand it to more people. But definitely try to sign up if you can make it, to network and meet with other CRPS warriors. And finally, the videos from the conference are being edited. I know we've had a lot of questions about them, and they're being edited, and we will upload them to our YouTube channel as we get them. So definitely keep an eye on our YouTube channel and subscribe so that you can see when those videos are live. And I said finally, but the last thing actually was that tonight's presentation is available. The link is on the Facebook video. I will make sure that I put it into the comments as well, so you can follow along with all the slides from this evening. I know I've said a mouthful, but Jim, do you have anything else that you want to share before we get started?
Welcome our warriors who have attended so many, and also any new ones. And I just wanted to make sure everyone knows that we have 2 Tar Heels on the screen tonight. We're very pleased with that. And Dr. Richard, it's all yours, sir.
Thanks, Jim. So let me pull up our slides here to do. I really welcome all you guys and for coming on. It's great to have you on, and I'm excited to be part of this. And for Alexis, those were very kind words that you had to say to start. So again, welcome everybody. I'm expecting we have a bit of a diverse audience. Some people who've unfortunately had CRPS probably for a long, long time, and then other people who maybe are new to this or new to RSDSA that way. Certainly, I think one of my own patients who surprised me to say she was going to be on it, who's a little newer to the disease and the process that way. So I can't deal with everything. I've been doing research in RSD and then CRPS for 34, this is now my 35th year, all in one town, Winston-Salem. Published a fair bit on it, worked with Dr. Harden, who I know is on your board, for many years on different projects. We'll talk about some of those things. I've been involved in all the meetings and was in Budapest for the Budapest criteria, so had a pretty active role in this throughout the years that way. These are some disclosures. I always feel I should tell you, I do, as I said, a lot of research with a lot of companies, and so you guys should know some of the ones. We'll talk a little bit about Grunenthal and Axome and Takeda as new sort of companies who've been in this field and some of the other things that are going on. I was told sort of a little bit by Jim and Alexis to focus a little bit on new things, particularly those who've been in this for a long time, maybe not so much on the pathophysiology or the mechanisms or what we know and what we don't know, but I'll sprinkle a little bit of different things in. The actual formal part of this presentation should take just about 15 to 20 minutes, so you can set your watches that way, and then I think we'll certainly have time for questions, and I know Alexis will be taking those and then giving them to me that way. So I'm going to talk a little bit about pharmacotherapy, a little bit about some of the local anesthetic blocks, just pick one thing that way, a little bit about some of the stimulation, both spinal cord and dorsal root ganglion stimulation, a little bit about ketamine, and then also on some new therapies that you may not have heard of and where things might be going. So I'm only going to show one slide. It's a bit of a cartoon that may show, and I don't know, Alexa, if my pointer works or not. I'm seeing it. I don't know if it shows up on the screen, but hopefully it does. So a lot of times almost always there's an injury of some sort in the periphery, in an extremity, and that sort of sets up this nociceptive pathway. And so it's all of our nerves in the outside of our body. It's a single nerve that projects to the dorsal horn of our spinal cord. And that's where all the action starts to happen, it seems like. So normally you have a pain fiber that activates this, and it goes up to the brain, and it tells us we have pain. So if you put your finger on a hot stove, it's that simple. It's one neuron connects to a second neuron, goes up through the thalamus and to the cortex and says, move your finger, stupid, it's on a hot stove. But that goes awry in the chronic situation. What we think is this is where you guys have probably heard a lot about amplification and different things that go on at this, what we call first-order neurons. So we have descending pathways that can block it right here. We try to augment those for people with chronic pain of all kinds to prevent what you also hear, sort of central sensitization in this regard. And you can think the brain, the power of the brain in that, you know, you've heard stories of things like people who get shot on the battlefield, and because their brain is so super activated, trying not to get killed, they don't even know they've been shot because their brain can shut off the pain processing right here from descending pathways from the brain. So the organism is incredibly sophisticated at that, but again, in some chronic pain states, this malfunctions or it's not strong enough, and so we try to get that back where it can help with pain sensitization and decreasing that sensitization. We think there's a feedback loop in many of us that what happens is this gets activated in a bad way through glutamine and other sort of excitatory amino acids, such that this goes back to a touch fiber. It should be a touch fiber, but because it's activated, then light touch can excite this and cause the same pain response. So now instead of being a touch fiber, it becomes a pain fiber. That becomes what we know as allodynia. So a lot's going on. There's a lot of research this way. Don't have time to go through it, but we look at this both from a physiologic standpoint, and we also look at it pharmacologically, what's going on. So here's some of the neat stuff that people are looking at. Is some of the big things are sort of cytokines. These are sort of mediators that seem to be augmented in certain ones in complex regional pain syndrome. The TNF-alpha was one of the biggest ones, and I won't talk much about a drug, lenalidomide, that we looked at and studied for TNF-alpha. Unfortunately, it didn't play out in CRPS, although I think it may have more of a role. It just may have been that was what we call a failed study, and it may not be a failed drug. But certainly, that was one of the important ones, and then you can also see some of the other ones that go on with monocytes, macrophage subgroups, and how they're changed in CRPS compared to the healthy volunteers that way. Another area that we've done a lot of personal research on is with, we look more at alpha-2 receptors. These are alpha-1, and you can see the alpha-1 adrenoreceptor seems to be upregulated in CRPS, and so again, that's one reason you hear a lot of us look at alpha-2 drugs like clonidine to try to bring down these circulating catecholamines, try to dampen down again through different mechanisms. The clonidine is very active on that descending pathway I showed you to try to help that way. It's also peripherally helpful with circulating catecholamines that Dr. Steve Brule and others have sort of opined on quite a bit. Here's a little bit of a study that was followed up on that suggested that patients who have CRPS have these autoantibodies against these alpha-1 adrenoreceptors, so a little evidence that way. So what are we trying to do with treatment, and where do we go? I still firmly believe early intervention's what we like, and again, it's hard sometimes. It can be a difficult disease to diagnose for some of our other colleagues who don't see it very often. We think if we can intervene early, we might be able to change the natural history. We might be able to prevent the changes to the dorsal horn of the spinal cord. Without question, physiotherapy is essential. I know many of you guys have trouble doing physical therapy because it hurts and the pain to do that is difficult. I think that's where your doctor early on can help so much. If he can just give you whatever medicine he needs to or other modalities to try and help so that you can do the physiotherapy. The body gets lazy. It doesn't want to be used in these conditions, so we really have to push it to try to do that. Sympathetic activity, if we get it early, sometimes if we interrupt that, really can help in that process and the ability to do physiotherapy as well. That spinal cord, that's where we try to modulate the central mechanisms. We're trying to prevent those trophic changes where you get contractures or there's skin changes or you have penciling of the digits, things that show for the unhealthy nutritive changes in there. And then there's so many psychosocial problems that often play into this. And you know, that's really the mind's ability to control the body. I always point to myself when I was coming out of residency and fellowship. I was so excited. I was taking on a great job and opportunity at Wake Forest, and that was good stress. But the stress, even at the age 30, I had developed about 14,000 PVCs, heart arrhythmias, just from the stress. So stress affects all of us in different ways. We all know people get ulcers from stress, and psychosocial problems definitely, I often say, they emanate and come out in the weak part of our bodies. If you've had an injury to an extremity, that stress will play on that. Sometimes it's the heart, sometimes the stomach, different things where stress can manifest itself in a physiologic way. Steve Brule is someone who has done so much of this work, at least looking at catecholamines, stress, other things like that. This is still one of the best reviews that he did. He's done a lot. I might recommend it to you. This is the British Medical Journal of 2015 and many other publications that he's put out on this topic since then. Mike Rowbotham's another leader who is looking at pharmacologic management of complex regional pain syndrome, and I'm going to spend some time on that. Back in 2006, you can see we were talking about bisphosphonates, looking at steroids. Again, I think early on they make sense. We talked about TNF-alpha. The lenalidomide study has now been published and was negative that way. But as you can see, 14 years ago, we were talking about that there hasn't been enough studies, that most of the treatment remains empirical. Unfortunately, a lot of that's true still today. This is another one with Wertley, which talked about bisphosphonates in early CRPS, and then maybe a shift over to calcitonin, more so than bisphosphonates in late CRPS. The NMDA analogs, I'll talk a little bit about, things like ketamine, some of the vasodilators have been used as well, and in some trials have separated from placebo. So this is Grunenthal. This is a study we did pretty recently. We participated in this study. We're one of the leading sites, I think, with it. Noridronate, it's a bisphosphonate, and they were very excited to try to look at this in regional pain syndrome. At the bottom, you can see the publication of Berena. This was a very positive trial with noridronate. It was a randomized, double-blind, placebo-controlled trial that came out in 2013. But after ramping this trial up in CRPS, it did not succeed. And in fact, you can see in the outline here that they had to come up with a decision that was based on the outcome of a pre-planned interim futility analysis conducted by an independent external expert. So they just felt there was no way they were going to make their primary endpoint, and they were quite discouraged, as all of us were. We thought this might be really our first treatment approved for CRPS. Similarly, Axum had, so the Grunenthal product was a systemic IV administration. Axum is an oral medication. It was also a phase 3. It was also a bisphosphonate. And you can see, unfortunately, here, similarly, they had an independent data monitoring group that looked at it. And this COAST 1, which is still exciting for them, this was an osteoarthritis. They were going to continue. But the CREATE 1, this is the trial that was in complex regional pain syndrome, was stopped because of futility again. So again, real disappointments for those of us who were studying these drugs. We were doing this study as well. You can see this is these were both press releases. The Grunenthal press release came out in 2019. This one came out in 2018. So unfortunately, I have to tell you, as of 2020, there's still no medications that are approved in the U.S. for the treatment of CRPS. We'll talk about some of these off-label, and I think, again, some things like bisphosphonates I still use in certain patients with CRPS and other things that way, but we have to just sort of keep trying. We have to find something that'll work, and I'm going to talk to you about a couple molecules at the end that I am so excited about this way. I do think here at the bottom, the growing evidence really is that long-term opioid use is most often detrimental in CRPS. I know patients are on them. My own patients take them, and we have trouble a lot of times trying to get them off them, even when they're not doing well. But I would caution a lot of you guys, if you're on them, if you can find ways to wean from them. It's difficult to get off them. Once you're off them, though, it's been my experience that a lot of patients, once the difficulty of getting off them, that their pain at best is no worse, and sometimes it's surprisingly better. So I know opioids are a controversial topic. I think they're better in short term, either in acute use or sometimes with flares, rather than taking them just for chronic use. I think that's the role they may have for patients that way. Here's a picture of the neck and the stellate ganglion many of you have heard about for the upper extremity. I just wanted to show you sort of an elegant study. I think it's a bit of an old study, but it's still one of my favorites. So this is actually the stellate ganglion. It's named because it looks like a star. It's protected sort of by the vertebral artery at C7, so we often block it up here at C6, and we let the medicine sort of push down. That's why if you've had these, we often sit people up afterwards. We want the medicine to come down. A lot of us stay out of the C7 because it's a little more risky with the vertebral artery. I would also caution you guys, if you're getting these, something I see, I do a bit of medical legal work, is to really avoid particulate steroids. If people are using some dexamethasone here, I think you're not going to hurt it that way. But usually the ganglion's not inflamed, so I think local anesthetics are what you need in this area. And this was a neat little study that was done with CRPS patients, and it looked at, this was double blind, so patients got, it'd be hard to do now because of ethical considerations, but they did blocks with just saline, or they did blocks with local anesthetics. And it was fascinating to me because it showed a placebo response, which we might expect with saline. Placebo is just something that happens in all trials that we do that are double blind. But you can see their placebo response lasted less than a day, and people were back to their pain scores. Whereas with lidocaine or bupivacaine, the medication itself only lasts 6 or 8 hours, not very long. And yet patients who got, when they got that, so each patient got both of these, so it was what we call a crossover design. So that when they got the lidocaine, bupivacaine, even though they didn't know which one of these they were getting, their pain relief stayed out to almost 7 days before it returned to 50% relief. So dramatic difference. Not a lot of patients, but pretty powerful in the sense of the difference between just getting the placebo and getting lidocaine. Sure, everybody got a little bit of benefit, but it was very short-lived if it was just a placebo block that way. This is an interesting study that just came out a little while ago that looked at 3-phase bone scans. Many of you may know those, and many of you maybe have had negative responses to it. But this study, which was reasonably large, 105 patients, looked at getting a bone scan 5 days before ketamine infusions. And in those patients who had a positive bone scan, it correlated strongly with those patients who responded to ketamine. Now, I have not tried to reproduce this. We don't do as many bone scans as we once did, but it's interesting if you've had a positive bone scan and not done ketamine, it may suggest that you may have a little more likelihood to respond to ketamine. And it also might suggest here, as these authors say, that ketamine is not restricted just to central mechanisms, but really may have peripheral mechanisms. We've always thought ketamine worked mainly in the spinal cord, as I showed you earlier, by modulating that neurotransmitter activity at the first order neuron. But this might suggest that it has a peripheral mechanism related to inflammation, bone remodeling, and that sort of thing. Ketamine infusions, again, it's a difficult topic to talk about. There's been so many studies. It's been so hard to sort out, if you will, what's going on with ketamine and when is it beneficial and what's the right recipe, what's the right amount, how to give it. We've done it different ways. We still do a lot of ketamine. I have found it to be very helpful with many patients, but it's still a bit complicated, and if you would not be alone if you're a little confused at how does ketamine work and in who does it work and what should I expect and so forth. This was a nice meta-analysis that looked at ketamine and showed a decrease in pain score in comparison to self-controlled baselines with a very strong p-value. Now, they admitted there was a fair bit of study heterogeneity. That means the studies were very different that they looked at. And you can see sort of the immediate pain relief, and that the pain relief usually was 1 to 3 months at follow-up. And so they did conclude, the authors anyway, that ketamine can provide clinically effective pain relief in the short term for less than 3 months usually. But again, if it allows patients to start physical therapy, to start getting circulation back to the extremity, I don't think ketamine should be done, in isolation. And I do worry a little bit about too many repeated ketamines. Nothing's, there was an interesting physician who lived in the Middle Ages, and his name was Paracelsus, and he had a great comment. He said, there's no such thing as safe drugs, just safe doses. So as you know, you can have liver toxicity from too much Tylenol. You can get water intoxication from drinking too much water. So every drug is safe in certain doses, and too much may not be good. So I think that applies even with ketamine. Too much and too many high doses can probably have some cognitive effects. So we need to be careful with the drug. But certainly for us, it has shown benefit in patients with CRPS. I'm not going to speak too much about spinal cord stimulation. You can see way back as early as, in the early 2000s, 2003, 2004, down here at the bottom, that spinal cord stimulation was effective for CRPS. There's been other reviews that have supported that, both American and European federations who've looked at spinal cord stimulation. More recently, we've talked a lot about these dorsal root ganglions. Most of that's been in lower extremity CRPS. I personally have had more success with spinal cord stimulation, but there are people who are certainly reporting success with dorsal root ganglion stimulation. So I think that's something you just should talk with your physician. It's technically a little more difficult to do the dorsal root ganglion procedures in that way, but both of these, as far as spinal cord stimulation, I think are things to talk about, particularly if you haven't responded to other treatments that way. So now I'm going to just finish up with a couple new things and just throw this out. This is very new. I've just gotten it myself and gotten trained and just treated a couple patients or starting into treatment. This is actually a percutaneous device. It's an electrical stimulation device. So it's a, some of you, I'm sure many of you have tried TENS units. A lot of you don't tolerate TENS because of the allodynia and the problems that way. So this is, what's new and novel about this is it's, TENS has always been very low frequency. So again, if you have a spinal cord stimulator, you know now that we can use high frequency 10,000 hertz in some of these new types of spinal cord stimulators, and that's been pretty revolutionary for some of our patients. And what this device is actually 20,000 hertz, so it's twice the highest of any of the spinal cord stimulators, and that seems to allow a much deeper and more penetrating charge, total charge into the body, percutaneous. Again, I have very little experience. I've seen some of the anecdotal and testimonial experience with this. It's very interesting that way, but stay tuned. We'll see how it does or how it plays out for some folks that way. Molecules, the last thing I'll talk about, and then sum this up and take questions. there are new biologic and novel molecules coming. Anti-nerve growth factors were one of the most exciting things I had seen in 30 years. These are monoclonal antibodies. They were primarily studied in osteoarthritis, but they also were being looked at neuropathic pain, not specifically CRPS. They ran into some problems with FDA because of side effects. They, at least in OA patients, they were causing some rapidly progressive OA. So the FDA put them completely on hold. They've come off hold. They're now fast-tracked. And the two leading candidates, Pfizer has one, tanezumab. Regeneron has one called finicimab. And these are finishing up phase 3 trials. I think they could be available within the next 12 to 18 months, maybe even sooner. It depends how all that gets worked out. But these were dramatically effective. They've had to cut back some dose, so it may not, we'll have to see how they work in things like CRPS, but I think they will get used that way. Probably more exciting, but a little bit further out right now, in my opinion, are these selective sodium channel inhibitors. They're very exciting to me. The two leading areas are NAV 1.7 and NAV 1.8. So we learned when we decoded the DNA and looked at genes in the human genome, we realized that people who didn't have NAV 1.8 or 1.7, there's a few groups of these people, you've probably maybe heard of them in India and Bangladesh, the guys who can walk on hot coals and feel no pain. They have no ability to sense pain. It's not very good for the overall body, but they really are what we call knockouts for NAV 1.7, 1.8. They don't have the gene in their body, so they really don't perceive pain. So they've been able to sort this out now, and they've been developing these drugs. Some of them have not been as successful, but Vertex, the company, has a lead NAV 1.8 molecule that's very, very exciting called VX150. It's had positive trials in 3 different types of pain: osteoarthritis, surgical pain, bunionectomy, and also small fiber neuropathy. So stay tuned. I think it's the most exciting thing out there right now. We've been doing trials in all of these. We've done the anti-nerve growth factors and the sodium channel inhibitors. The sad thing for you guys, they're so specific, they won't, they have very specific inclusion criteria, so we don't have access to these right now for our CRPS patients. So, sum it up with one slide, and then love to take some questions. I think the improvement still comes by understanding the pathophysiology and the clinical manifestations of CRPS. It is a heterogeneous group in its presentation. Some patients, lucky, and I always say that to folks, can get spontaneous remission. Are they cures? I think they are, and I've seen that in my town, in my practice, having, again, not a big town and been here 35 years. I've seen people I've treated who were marathon runners who got CRPS, who got better, got back to running, so on and so forth. So stay optimistic. That's one thing I tell people for sure. Treatment somewhat is anecdotal in a lot of cases, unfortunately. We don't always have the studies we'd like. I do think most of the time we really need to have multidisciplinary care. We talked about it, physical therapy, psychosocial support and structure to that, and then interventions and pharmacotherapy. It often becomes that type of approach. One single thing doesn't usually cure the disease. And we really do need more trials in all therapeutic areas to guide therapy. So I thank you for that, for letting me. I hope I didn't bore you. I hope I had a little something for everybody. That was my goal. And I'm going to turn it back over to Alexis now and see how any questions there may be that way. Thank you.
Awesome. So I'm going to bring Jim back as well.
Hello.
Hello. All righty. So we do have a few questions, and I just saw one from Debbie, I guess just to kick it off. So she asked about ketamine and like your liver. Like, how does ketamine affect one's liver, if at all?
So the liver you can take too much ketamine. That can be hard on the liver. Usually in the doses we use, you're not going to see effects on the liver. I worry more about cognitive or brain sort of changes over time with too much and too frequent use of it that way. So again, you'd have to be a large dose, I think, or a lot of infusions. We used to do week-long infusions in the ICU with ketamine and never saw liver problems in patients that way. But again, You know, I think too much of anything is possible, but I worry more about possibly long-term cognitive changes if one undergoes too much ketamine. There's a little data, but that's so far it's a little bit soft that way too. So.
Okay. We have another question that just came in from Colleen. So we often hear people talk about, you know, going into remission, and a lot of people wonder, like, what does remission actually mean? So does this mean that, you know, that this person does not have any symptoms at all, or can you just kind of talk about remission a little bit?
Sure. Yeah, that's a great question and one that's good. So, you know, we are always so fearful of talking about cure, but I really do think it happens that way. You can be cured of this like you can any other disease. There's no reason people can have headaches in parts of their lives, and for whatever reason they get over their headaches. Sometimes it's just a lot of factors that drive that. So I have seen that many times in my own career, that people, we can call it remission, we can call it cure. I do, when people come back to me though and they're in remission or they're cured, they say, you know, doc, what can I do or not do? What should I do? And things like that. And I have another girl I still see, you know, lady now who I followed since she was reasonably young, and she now back, and she asked me, can I start going snow skiing again? I love that. She had it in her lower extremities. I said, you know, you've been out long enough. I think, why not? You know, we have to live our lives, and if that's something that really means something to you, to do it. And she's been successful at that. I do think you put yourself a little bit at risk of a subsequent injury. You might be a little bit more susceptible to CRPS, but I've had folks in remission or cures, I think of them that way, who have had injuries, you know, sprain another ankle, or they strain something, who don't develop CRPS under the second situation that way. And they usually are much more knowledgeable if they do have a re-injury to get treated quickly and to get through the process. So, you know, I do caution some folks to particularly say in a workplace, if you're in remission, I certainly wouldn't go back if you can avoid it to repetitive work or things that would maybe flare it up. So a little bit of caution, a little bit of common sense. But again, if you're lucky and you can get into remission, then I think trying to live your life. An analogy, I use, Alexis. I've been fortunate in my life, sure, but I did blow out both my knees playing basketball in my 30s. Had both my ACLs reconstructed, and I just made the decision to quit playing basketball. I love the game. It was my life. I played, you know, quite a bit when I was younger, competitively and otherwise. But I took up cycling, and cycling's been a great sport for me up to, you know, my age now. And so I think, you know, sometimes you make a little bit of choice. It doesn't mean you have to stop living. It just means sometimes you have to sort of find your joy and pleasure in a little bit different things.
Dr. Rauck, may I ask you about, what about people with long-standing CRPS? If they come to you haven't had it for years, could you help them with getting into remission if they haven't had the good treatment yet?
Sure. I'm probably the eternal optimist, Jim, so I always believe that, but I've seen it happen as well. You know, and so much of this, the body, it's probably, if you've had it for a long time, it's not going to get better, you know, quickly. I always tell people it probably doesn't get bad all at once. It's kind of a downhill, you know, path to get to some place. But you can reverse it. There's no question in my mind that way. I've seen it, and I've seen it. It is often hard work. It's one of the most painful conditions we have that we know of. You know, when you look at scales and how people write it and how they describe it and things, and my experiences as well that way. But I know people change, and their bodies change, and their stress levels, and all kinds of things that can change, that people can get over this at any point, no matter how long they've had it and how bad it's been. And again, if they don't get 100% beyond it, they get back to, and this is an important thing, I think, that I've kind of changed some of my thinking, Jim, on how I look at life and pain in a way. You guys spend all your time with your doctors probably hearing them say, what's your pain, 0 to 10? What's it 10? Is it 6? Is it 7? We argue about this all the time. I sometimes think it's more helpful in a way to think of pain as a binary constraint. So to me, a lot of times my patients will hear me say two things. Your pain is either tolerable or it's intolerable. If it's intolerable, then we have to do something. We got to work like crazy, do everything we can to make the pain tolerable. And tolerable is different to all of us. It's not a number. It's not anything else. It's simply, I can at least deal with this pain. I can get on with my life. I can live things, maybe not everything I'd like to do, but it is tolerable, and I'm living with it. And so I think sometimes both for us as doctors, we should reframe what our goals are, and a little bit for patients as well. So I don't know that, Jim, I can always get them into remission or cures completely that way, but I do hope most of them I can get it to where they feel their pain's tolerable.
Thank you.
So we have a question from Caroline who says, you know, are there still any treatment centers for CRPS that someone can go to and get intense multiple therapies? I know a lot of people are familiar with, you know, Sparrow Clinic down in Fayetteville, Arkansas, but, you know, are there any other treatment centers that are similar to that one?
Yeah, there, you know, certainly Norm had one of the best ones up at Northwestern in Chicago, and I think it's still going on. You know, Norm sort of is now down in Georgia, so I don't think he's running it that way. There was certainly a very successful sort of adolescent girls one, and I think is still running up in, I believe that's at CHOP, the Children's Hospital of Pennsylvania, up in that area. And there are some other, and I think if Carolyn's asking it this way, you know, there are places you can go for 4-week treatment plans who really work hard. I think Miami still has a very aggressive rehabilitation center that's still sort of an inpatient program and really works hard with allodynia and other things of that nature where patients are very active in that. They've been harder. We have, but we do still have an inpatient program. I don't direct it, but it's over at Wake Forest, and they work with patients with CRPS in that framework. So there are versions of this. Nashville, I think Steve Brule and his team are still doing that. Nashville has used to have a very active program that way, and I think they would still have that.
Also, the Cleveland Clinic and the Mayo Clinic have programs. A lot of times people have to put together their own team, and it's more difficult.
Yep.
Definitely. So we have a question that came from Brandy and Kathy. So they're asking about your thoughts on hyperbaric treatments.
Yeah, I didn't bring much up on that. You'll hear a lot of different things about it. It's, you know, I think I'm of the opinion that if things work to, you know, and things, particularly if they're not harmful, sometimes we don't always understand the mechanism. I've certainly seen patients who feel like hyperbaric has helped them and hyperbaric oxygen has helped them. I don't particularly understand the sort of the mechanism of why hyperbaric necessarily might help. But, you know, I've read about it. There's certainly opinions on why it happens with things like CRPS, and there's certainly a place in Florida that's very active with hyperbaric oxygen that way. But I don't have the personal experience to speak too much to it. I know I've read on it. I've certainly looked at it. I know some people who are quite passionate about it, and certainly patients I've heard who feel like it has benefited them, but that's probably the second.
We have a question from Elizabeth who wants to know about IVIG. I'm not exactly sure what that stands for. I'm sure you do. And small fiber and CRPS.
Yeah, so sort of IgG, which is, you know, one of our main sort of, you know, immunotherapy kind of approaches. There's IgG, IgA, IgM. And some thought that IgG, it's an immunoglobulin is what it is, and sort of important in some sort of maybe anti-inflammatory mediators. That's reasonably experimental still. People are looking at it. I don't know of any studies that have looked at it in any large scale or otherwise with CRPS. I don't have any personal experience with it. I think it's if you have somebody who you know, wanted to try it and he had access to it and other things have failed, I don't think from what I know that IgG should be harmful to you that way, but I don't necessarily support it one way or the other right now.
We have a question from Brittany. It was the first question we actually got tonight, and it's something that I've wondered too. I know Jim's wondered. It's just like, why don't more physicians really like understand CRPS? You know, of course, if more physicians understood, then, you know, people would obviously get proper care. So why do you think that is, or what are your thoughts there? Why is it not really taught in school?
Yeah, I don't know if I can answer why it's not taught in school. It's actually, you know, it's still not as frequent. We're kind of here at the Mecca where it all is, and everybody thinks, and you got here, it's as common actually as people might think. I think what happens is people can get sort of parts of CRPS, or they get certain things. They may get some allodynia after surgery for a little while, or burning pain, but it often resolves as it should. So true sort of CRPS that becomes chronic and unremitting is not quite as common as we think. So I think that's one problem. The primary care, they just don't see it enough in their practices and things to become familiar with it. And then it does present in so many different flavors in some ways that I think that fools clinicians into thinking something else might be going on. But trust me, Brittany, you're preaching to the choir. I wish it was taught more in school. I wish people would understand it more, because to what I said earlier, if they did, then we could get started on treatment earlier, and I believe we could be much more impactful in sort of not letting people develop the chronic problems that you see with CRPS if we started treating it more effectively earlier.
We have another question from Lois Ann. She's asking, what makes a patient a good candidate for bisphosphonates? And do you take out-of-state patients for bisphosphonates?
So we do take out-of-state patients, that's for sure. And, you know, as I said, I think it's a little bit as it is always in today's world, is getting insurances to pay for it, because it's been kind of split in all this data as to the benefit or not. I just am doing a trial with one patient with bisphosphonates now who seems to think it's helping him. We'll see if it holds up that way. So as I kind of went through it a little bit quickly, but some ways we thought bisphosphonates might be better in early parts of CRPS, so those patients, but that's not really true for everybody. So because everybody progresses differently through CRPS, so it's a little hard to know that. But certainly, if someone wanted, we could certainly look into see if we could get it approved for them before they came here, if they were coming from out of state, so on and so forth, or if they have the means, we could look into the cash price or let them know something about that. But clearly, if you have CRPS, support a trial of bisphosphonate.
Dr. Rauck, could I ask you about if you could talk about systemic complications of CRPS? There's a lot of controversy regarding can CRPS affect the organs?
Yeah, Jim. People talk about that. I'm not a big fan of that kind of construct. I trained under some people. It's been a while, and how we thought of CRPS. In fact, and I know some of you out there will have had sort of more widespread CRPS in other joints. I think in other extremities, I think if you really develop that type of CRPS, one needs to really go back and do a deep dive into what is going on. And I mean that there are other immune and autoimmune disorders that can mimic CRPS in their early presentation. So I have certainly had patients who I thought had CRPS who really that was the initial manifestation, and went on to develop things like lupus or scleroderma or Sjogren's. There's just a whole variety of different autoimmune disorders. So I think I just don't think you ought to have organ involvement with the disease from what we know. That's more of a vascular etiology, and again, sometimes it's really hard to understand what the pathophysiology and give it a name to it, but the CRPS, historically really has not been an organ kind of problem that way.
Thank you.
So we have a question from Allison, who wants to see if you can discuss low-dose naltrexone and just any long-term problems that you've seen or heard from that.
So we've seen no problems with it. I'm a fan of low-dose naltrexone, and we have used it successfully in maybe 15 or 20 patients. So I think it has had a place. And still the data is not maybe as robust as we'd like, but we certainly think it can be helpful in some patients. I haven't used it exclusively in CRPS. So again, most of the work with naltrexone that way has been somewhat anecdotal, but if you have somebody who's interested in it and you can get a physician to look at it for you, I would encourage it. I think, I don't think it has any long-term harmful effects that way. I think it is not going to be anything that has any bad effects at all on somebody.
And similar question, from Beth. Could you also talk about long-term use of medications like Lyrica, or if there's any side effects or problems there?
Well, there's certainly side effects. Lyrica, you know, you hear a lot of people talk about weight gain with it. Some people get constipation with it, not as much as probably the weight gain is the biggest one. Some people, these are what we call cognitively active drugs, so some people get a little confusion or just mental clouding with it that way. It has been actually a very safe drug on organs and things of that nature, so I don't think I've seen much of what I'd say, you know, when you see the drug does organ toxicity that I've seen with Lyrica in that regard, but there are certainly side effects with it.
We have a question from Lydia who's asking about, you know, easing the burning all over. She has chest tightness. Like, what types of, I guess, or what types of things can people do to kind of resolve some of the burning that they're having? Obviously, they may not be able to resolve all of it, but what are some things that you've seen have worked with other people?
Yeah, so when it gets like that, I think, you know, and I don't know, we never talked that CRPS sort of morphs into more what we call widespread pain syndromes, but, and that probably, there's just overlap in some of this, and so, you know, it does sound like that's something more that becomes maybe not fibromyalgia, but certainly a central sensitization state, and, you know, I think now I see more and more a term being used of AMPS, which is amplified pain syndrome, where the whole nervous system becomes amplified that way. So I think then, you know, you have to look at some of the more systemic treatments. So again, pharmacotherapies. It's hopeful that some of these sodium channel blockers may really help with that because, again, their benefit with small fiber neuropathy. I think then you can start looking at some, I would advise some alternative therapies, you know, whether, again, it's things like hyperbaric oxygen or cryoanalgesia or different things that might just, it's a little bit like I think they do in politics too much, everything at the wall and see what, you know, they got it that way. It's a little bit that way. So I do think sometimes we just have to sort of try a lot of alternative therapies in those situations.
Have you had any patients who have found success with using medical marijuana or CBD for their CRPS?
I am a big proponent. I'm in a state that doesn't allow for medical marijuana, but we, you know, certainly CBD has been really good for us. And patients who move into other states and people I've talked about who use medical marijuana, I think it helps a lot. I would much rather have a patient on medical marijuana or CBD than on benzodiazepines. I think it can certainly help significantly with anxiety, but it's so much safer than a benzodiazepine, particularly if you're on opioids. So I think I've had good results with CBD for sure in our state, and I think a lot of physicians where they have medical marijuana, it's been helpful for CRPS patients.
Definitely. And Jim, do you have any other questions? Anything that you see that I may have missed?
I saw one question about Namenda. Would you be using that in your clinic?
Yeah, I've not used Namenda myself. I know a little about it, but I've not really used it, so I can't speak too much to it that way.
Okay. I think that's basically what I saw coming.
Challenged me. These were great questions. Keep me on my toes.
Definitely. And I know everyone, hopefully, unless you're new here, this video obviously will stay on our Facebook page, and we also add it to YouTube. So you may get some more questions over on YouTube as well.
I'm not much of a social media folk, but I do have someone who monitors it for us. So yeah.
Definitely. Well, thank you once again for all of this great information. And like I just said, as always, this video is going to be pinned to the top of our timeline for easy access. If you want to rewatch, we're going to also add to our YouTube channel along with our conference videos. And we will also be sure to add a link to the presentation there as well. It is also in the comments of the Facebook Live if you are rewatching this on Facebook. So if you have any questions for us, RSDSA, if you need a support group, if you're looking for a new physician, or if you want to tell your story on the RSDSA blog, we are always looking for warriors to tell their story on the blog. Of course, just send us an email at info@rsds.org. That's it. Have a great evening, everyone.
Thanks, everybody. Bye-bye.